Okay, it looks like it's about almost 3:05. We're gonna go ahead and get started. So, hello everyone. My name is Rola, and I'm the Vice President of Events for Students of Global Health organization here at UCSD. I wanted to say a huge thank you for attending Fall Quarterly Conversations in Global Health. Please note this event will be recorded and posted online, so please keep your video turned off and remain muted throughout the presentation. By remaining on this Zoom event, you consent to these conditions. And now, Colette will be making a few announcements regarding exciting upcoming events for global health.
Hi everyone, my name is Colette and I'm this year's President for Students for Global Health. Before we begin, I just wanted to say thank you so much to Rola and the Events Committee and GHP Advising for putting this on. I'm so glad that so many people came out. We just wanted to highlight some of our upcoming global health events and we hope to see you there. So directly following this session is going to be an information session on the master's program in global health. So again, that's going to be today after this Zoom, and you just need to stay on this link so you don't need to go anywhere else. And then next Monday, we're hosting GBM2 for Students for Global Health. I think you can sign up for the Zoom link on our Facebook, and that's going to be from 5:30 to 6:30. This is going to be a really great opportunity to meet some of our board members and learn what the organization's about. And we also have a couple board positions opening up, so we'll be discussing openings and applications. So keep a lookout for an email from the GHP Advising and check out our Facebook for more information. And additionally, for those receiving extra credit for your global health classes, there will be sign-up sheets once the event ends online.
So now I would like to bring up this afternoon's MC, Dr. Thomas Shortash. He is the Global Health Program Director, and he will be our MC tonight.
Thank you very much, Rola. I'm Professor Tom Shortash, professor in the Department of Anthropology and the director of the Global Health Program. Welcome to Fall Quarterly Conversations in Global Health. Our Quarterly Conversations is a recurring event at UC San Diego made possible by the Global Health Program, the Students for Global Health, and the Global Forum. I want to particularly welcome our incoming and returning students in global health, and particularly our second cohort of students in the Masters of Arts in Global Health. As we all face the stark pandemic reality that global health is more important than ever now in all of our lives. As with all of our events, the goal is to bring the global health community and the local San Diego community together to discuss important issues in the field. Though we're forced into the technological solution provided by Zoom, we also have to acknowledge the unintended benefit of being able to meet or to reach a much wider audience than with our usual live events. And I'm told that we have as many as 486 people registered for the quarterly conversations today. And so a warm welcome to all of you. Before we begin, let me express special thanks to our co-sponsors and individuals that have made these events possible this year. We first of all like to thank the Global Health Institute, the Center for Global Mental Health, and the Global Health Program for providing support and sponsoring this event. We'd also like to give a huge thank you to the community and student organizations that are tabling here today for spreading knowledge and resources on such an important and relevant topic. Finally, I'd like to thank the Events Committee led by Global Health student Rola Kojak and comprised of board members from UCSD Students for Global Health, as well as our Global Health Advisor, Erin Warren, and Program Coordinator, Brittany Wright, who all contributed to putting together this afternoon's conversation. Given the extra challenges, I want to make certain we give abundant thanks to Brittany and Erin, and not only for this event, but for everything that they do. Before we get into hearing from our panel of speakers, We'd like to begin the event today by highlighting some of the organizations on the UC San Diego campus and in the greater community that are part of our network and our global health family. In our usual quarterly conversation format, our tabling organizations are set up in booths at the physical event, explaining how their work is related to the topic at hand and providing resources on how to get involved. Because of the nature of our virtual event, we'd like to invite our tabling organizations to speak for a few minutes and share a bit about the work they do and how it's related to the COVID-19 pandemic. And I would like to begin by inviting Dr. Jose Luis Burgos and Dr. Victoria Ojeda to speak about the Health Frontiers in Tijuana, also known as HFIT program at UC San Diego.
Thank you very much, Dr. Shordas, and thank you for inviting us. So I'll share a video to show a little bit, so students know a little bit about the program we have with the HFIT clinic. And let me see, I'm not sure it's, okay, so I'm gonna share, let's see if this works. Okay, so, let's see. Oh, it's not letting me share. Okay, yes, okay. So, yeah. Okay, so I'm gonna share a video and I'll kind of talk to you about the clinic. So, the HFIT clinic is a program that was developed between UCSD students and UABC students and faculty, and it's a true binational team, not only between faculty, students, but also community members that have become part of this. And, HFIT has been, we have two sites. We have a site in downtown Tijuana in the Red Light District where we have a transgender clinic. There is not, right now it's not operating because of the COVID-19 clinic. And then our second site is in the Padre Chava soup kitchen in the second floor, where right now, we are operating and we're inviting students to come virtually to see what's going on, and learn about global health. The HFIT also has become a site where faculty, we have done research based on these sites, and students have also done many of their student-led research or mentorship. But we started in 2011. The program has grown, because of all the situations that is happening. And when the COVID-19 appeared, we were not sure if we were going to go on to the following quarters, but our partners asked us to stay, asked us to help them because, people need to eat. The soup kitchen is still operating and people need healthcare. And so the clinic is ongoing. And let me see, I don't know if this is, maybe we need to accelerate a little bit. Yeah, it's ongoing. And I'm not sure why this is not changing. Oh, maybe. I think my computer kind of, yeah, so, well, well, I'll just let you know. So, so we decided to continue with our program. We have been working with Dr. Ojeda. She couldn't be here today because of an emergency she had, but in how do we bring students into these sites? How do we help them learn about global health, and also learn about what's going on here at the clinic? And maybe this will work. Sorry guys, I don't know, my computer is broken. So so I'll stop sharing, since this is not working out. Yeah, so yeah, that's right. So so basically, we decided to go on with the program. We have a triage, downstairs, instead of having patients go up into the waiting room and have students interact with them, we have students in video conference helping us register patients, helping us do questionnaires. We have medical students from Mexico and from UCSD shadowing consults and, and working with with us in learning about global health. So we kept going, and it's been, we've been keeping everybody safe so far. As far as we have 2 providers and some volunteer providers that come. Nobody has become ill with COVID-19, and we even had some events where the soup kitchen usually feeds over 1,500, almost 2,000 vulnerable individuals in the border region, many of them refugees from different parts of the world. And right now they're providing food, like as people go by, they get their plate, and they eat outside, to prevent spreading of COVID-19. So we have the dining room with safety measures we've used to do community events. We connected residents from other parts of from UCSD and from other parts, and we keep going, so invite you guys to learn about HFIT, to be part of the HFIT group, and learn about and deal with the current situation. Yeah, I don't know about time. How much time do I have? Because I know it was a short time, but I don't know if I've extended myself or.
Yeah. No, that's good. That's good where we're at. Thank you, Jose Luis. I should say that HFIT has been a very close partner of the Global Health Program since the beginning, and we established the student internship at HFIT quite a few years ago. Many students from the Global Health Program have passed through the internship program, and more recently, Dr. Burgos and Dr. Ojeda have started offering it as not only a global health experience, field experience opportunity, but also as a class for credit in addition to that. So our partnership goes on and becomes closer all the time. We're really grateful to you, Jose Luis, and to Victoria for your partnership and collaboration. Next, we'd like to invite Lauren Ibarra from the International Health Collective to speak.
Hello, I'm gonna share my screen really quick. So hi everyone, my name is Lauren Ibarra. I am the current administrative director at IHC. IHC is a completely student-run organization here based at San Diego with faculty advisement from professors at the medical school here at UCSD. And basically what we do is we work with rural communities in Tijuana and as well as communities within San Diego to alleviate health disparities. Specifically, we run a clinic at a community called Tijuana Progreso for about once a month. And we also have bi-yearly clinics in another community about 16 hours away from the border called San Juanico, as well as some opportunities to volunteer at a women's health clinic in Tijuana called Preven Casa. And here at IHC, we pride ourselves on being a need-based organization. We are very collaborative with our communities and focus a lot on holistic health and health education. So right now during COVID, our clinics at Tijuana Progreso are all virtual. And what we have done is we have actually had some of our board members go to our community and work with the community health workers there to teach them how to triage, and they triage our patients beforehand, and we have specific times in which patients come, and we have opportunities for students to scribe or translate for our physicians via Zoom, as well as just shadowing and being able to receive mentorship from these physicians during this time. And a big part of how we've adapted to COVID is really leaning into our health education aspect. So we're focusing a lot on providing pamphlets, infographics, and videos that are adaptable for our communities, focusing on not only general health needs such as medication education, sex education, diabetes, but also our amazing community health program directors have been making pamphlets and infographics related to COVID and related to destigmatizing any rumors or any false information that is going around about mask usage, about getting care, and really curating that specifically to our communities so that they can access the resources that are available to them. So if you guys are at all interested in hearing more about us, make sure to follow us on our social media, as well as our website. This quarter, we are actually having rolling admissions. So you can apply at any time, and our applications are going to be found on our website, as well as you can contact myself via the email on screen or any of our other board members. Thank you.
Thank you very much, Lauren. Next, we'd like to invite Mariah Hayes and Anthony Hurtado from the Native American Student Alliance to speak about their organization.
Hi, I'm gonna share my screen real quick. I'm Mariah Hayes. I'm a fourth-year communication major. Anthony, do you want to introduce yourself? I'm the co-chair for NASA, Native American Student Alliance.
Hello, everybody. My name is Anthony Hurtado. I am the other co-chair for NASA. I'm a third-year public health major.
And our undergrad organization doesn't necessarily relate exactly to COVID or public health, but we are a campus, a undergrad organization that's focusing on healing our Native students and kind of, bringing an Indigenous perspective on this. We really just like gathered together. We have a space that we can just really be safe, and like it's specifically for Indigenous students to, come together and, hang out, talk about whatever it is, and have really a space where we can feel comfortable and be unapologetically Native.
Right, yeah, like Mariah was saying, we create a space where all different types of Indigenous students or even allies can come together and create a space, because with UCSD being a very large campus, it's hard to find a space where we can all connect with each other. And so we try to provide that to all of our Native students. And right, we're still a very small presence on campus. So we've been working very much in conjunction with the Intertribal Resource Center, which is located on campus. And that's also tailored to Native students and their needs. It's a space, a physical space where we can all come together, right? And yeah, we've been working a lot with them in terms of community-based outreach. So we've been doing a lot of that kind of stuff and reaching out to all of our Native communities beyond UCSD, because I'm not sure if you're aware, but there's San Diego County alone, there are 18 federally recognized tribes. That's the most in any county in the US. And so we have a very large population surrounding our university. And so we try very hard to create what do you call it? Like a bond with all those communities. So that's what we're working hard at. And if any of you happen to be Native or Indigenous, or you're interested in being an ally, you can reach out to us through all of our emails here posted. We also have a Facebook page where we post information regarding NASA. And yeah.
Yeah, and as of now, our GBMs are even week on Mondays at 6 p.m. So thank you.
Splendid, thanks. Thanks to Mariah and Anthony from the Native American Student Alliance. Lastly, we'd like to invite Tiffany O'Mara from UC San Diego Counseling and Psychological Services, also known as CAPS, to speak.
All right, thank you so much for having me. Hello, I'm Dr. Tiffany O'Mara, the Director of Outreach at CAPS, and I'm here to speak with you about Counseling and Psychological Services, otherwise known as CAPS. And this slide here shows you our CAPS team at UCSD. And we're comprised of a multiple disciplinary team made up of psychologists, licensed clinical social workers, psychiatrists, administrative support staff, and postdoctoral residents. In addition, we have a culturally diverse staff at CAPS, and we offer CAPS services in various languages, including Cantonese, English, Farsi, French, Hebrew, Mandarin, and Spanish. And we have counselors located all over campus in order to help increase access for our services. All right, so during this time of COVID, CAPS is fully operational and all of our CAPS services are offered virtually. And if a student is interested in counseling services, you can call the CAPS Central Office phone number to schedule a brief telephone assessment, that's known as a BTA. And during this time, it will take about 15 to 20 minutes for a phone assessment, and a CAPS counselor will confidentially speak with the student about their concerns and what's bringing them to counseling, and they'll help direct them to the right resource for their concerns. So based on the information that the student shares, the CAPS counselor may make a variety of recommendations, and there's 4 primary recommendations that you can see there. And students are sometimes provided with a combination of recommendations. So those recommendations might include focused intermittent therapy with or without psychiatry services. So CAPS offers individual and couples counseling, as well as psychiatry services, which are free and confidential to currently registered UCSD students. And we use a focused intermittent model of counseling. And these services are available to all students who are currently living in California. So due to licensing restrictions for clinicians, as dictated by the California Board of Psychology, we are not permitted to provide these services outside of California. We can only provide counseling to students who reside in California during the time of service. However, we can consult with students living outside of California or outside the US to help them find local resources in their state or home country for counseling. Another resource that we might direct students to are one of our CAPS groups, community forums, a drop-in workshop, or iFlourish. So some concerns such as getting nervous in social situations, relationship challenges, feeling lonely, group counseling can really be very helpful. We also offer drop-in workshops. So these workshops are designed to help increase skills, to help students learn how to manage stress and build resilience. And then we have community forums, which are identity-based groups that help students make connections with other students to help build community and a sense of belonging. And then we also have a new online self-improvement program called iFlourish. And all of those services are available to all students no matter where they are located. And the best part about these services is that they are free, unlimited, which means that students can attend as many as they want. You don't have to make a commitment, so you can attend one or attend all of the workshops. And you don't have to be a CAPS client to attend. You can bring a friend, and there's no wait for any of these services. A third option is that some students may be referred off campus for longer term counseling, and CAPS provides step-by-step support for students that need to connect off campus with counselors for more frequent counseling. And then the fourth referral might be to student health services for a medical related concern, or to a community resource based on your needs. The other thing that I want to let you know is that we do have emergency and crisis services. So if a student needs to consult with a mental health provider immediately, they can call the CAPS Central Office phone number, the same number that's up there, and there's a counselor available to speak 24 hours a day, 7 days a week. So all of our recommendations are individually tailored to best meet each student's needs. So I am going to also post in the chat some links to some of our services where you can find more information about some of these services. Oh.
Thank you, Dr. O'Meara, and thanks to all of our tabling organizations for the work that they do and have been doing during this unprecedented time. The coronavirus or COVID-19 pandemic has upended all facets of life across the globe, from physical and mental health care to the economy and labor workforce to education to international relations. While researchers are rushing to understand the virus and develop a vaccine, the response from different nations throughout the world have influenced how individuals are navigating and curbing the spread of COVID-19. As members of the global health community, we naturally ask several questions about a disease that does not recognize borders. How did we get here? How are communities being disproportionately impacted, and how do we support them during this time? How might this virus change health policy? Today, our discussion will center around interdisciplinary perspectives in global health to better understand this pandemic. Our speakers today are Dr. Robert T. Schooley, Distinguished Professor in the School of Medicine, Division of Infectious Diseases and Global Public Health at UC San Diego, and Senior Director of International Initiatives here at UC San Diego. We have Dr. Mia Lozada, a general internist at Gallup Indian Medical Center in New Mexico, who is also an assistant clinical professor at UC San Francisco. Dr. Jenny Wei is internal medicine physician at Gallup Indian Medical Center in New Mexico, and also assistant clinical professor at UCSF. Dr. Timothy Stenzel is director of the Office of In Vitro Diagnostics and Radiological Health at the U.S. Food and Drug Administration. Each speaker will have 10 to 15 minutes to introduce themselves and present. But our first speaker is Dr. Robert Schooley. Dr. Schooley served as head of UCSD's Infectious Diseases Division until 2017, and now serves as Senior Director of International Initiatives for the university. He's a distinguished professor in the School of Medicine and has become deeply engaged in the university's response to the SARS-CoV-2 outbreak as a lead on the Return to Learn program. I must say that Chip Schooley has been a longtime friend of the Global Health Program, back to 10 years ago when we first started out, and he was a guest lecturer in the course on HIV, AIDS, and global health that I co-taught with Dr. Joe Caperna. He's stood by us and supported the Global Health Program since that time, and we support him. Please give a warm welcome to Dr. Robert T. Schooley.
Thanks very much, Tom. It's a pleasure to be with you today and with all the Global Health Program and all the great things that the program is doing and has done in the past and will do in the future, particularly in the context of an epidemic that is rattling all of our cages around the world. I think if anything that has happened in the last 100 years should help us understand how we are globally interconnected from the perspective of health, it has to be the coronavirus outbreak, which initially was noted back in December at a time when many people wrote it off as something relevant only to China. Now it's very clear that from the very beginning, we should have all taken this seriously as a global community and dealt with it in a much more constructive and unified way. We'd be in a very different place today. What I'd like to do is just spend a few minutes talking about the U.S. role in global health and how in this particular epidemic, our performance has been at the very best mixed and set a stage for us to talk about ways we might do better in the future. I'd like to share my screen if I can do that, and let me see if I can set that up. Can we get, I'm going to go ahead and stop your screen sharing, Tom, if that's all right, and then switch over to mine.
Go ahead, Joe.
Let's see if we're there. Are we there on this one yet?
Yeah, we can see it.
Okay, so I'll go to so let's talk about kind of the epidemic. These are numbers that everyone is well aware of. As you remember, when things started out about 9 months ago now, people were shocked to see as many as 1,000 or even 10,000 or ultimately 80,000 cases of this disease in China. But what we've seen since that time is a rapid spread of the virus around the world to the point that we've now had nearly 40 million cases in virtually every country of the world on every continent so far except Antarctica. The US, which sat by watching for a while with even some of our political appointees in high places in the administration, said things like this might even help us with our competitiveness with China in somewhat of a gloating way. California has been hit as well. We're approaching 900,000 cases. We've had 50,000 cases here in San Diego, and tragically 1 million deaths around the world, and almost a quarter of a million deaths in the US headed in that direction. What you can see from these two epidemic curves that are highlighted are that this epidemic has been one that's been kind of in roller coasters. And the roller coasters are important to understand because what they tell us is that when we get together and make concerted action, we can have a major impact on the number of new cases per day, as Europe in particular did back in the late spring, and as the US began to do, but then failed again to do as the summer began leading to the second wave. So this is not an epidemic in which we're currently helpless in terms of dealing with the problem. It's more an epidemic that, in my view, we haven't had the collective will to do the right thing. Now, what can we do? What are our roles constructively for the US and global health? Well, we really are and have been for many years the preeminent force in terms of biomedical research in developing drugs and vaccines and other prevention and treatment modalities. And in the case of SARS-CoV-19, the only antiviral drug that has yet been shown to have an impact on the disease, remdesivir, was developed here in California. There are other drugs coming along, and I think it's very likely that we will play a major role in drug development. Vaccine development is more of a discovery, and development is more of a global effort. There are very strong efforts ongoing in a number of countries, including the UK with the Oxford Group, many in the US. But this is still, as I'll discuss in a few minutes, a very unfinished endeavor, and one that we have to be very careful about trying to overpromise and oversell, because it can be extremely destructive in terms of our global response. Dissemination and development of best practices in public health, something that we could do, but we have failed to do in our own country. It's very hard for us to lecture other countries about what they could be doing that they're not doing based on our own response, where we're seen around the world as being perhaps the poster child for doing things wrong. We also in the past have been very much an investor in public health in other parts of the world, providing financial assistance and technical assistance in other parts of the globe. And here, I think at best we can say we've pulled up the bridges, filled the moats, and retreated from the global problem as we've obsessed with things going on here. And then finally, providing political leadership for the world. It's very hard to argue that the US is currently doing that, as we've pulled out of organizations like the World Health Organization. How do we do damage? The biggest damage we've done in this disease has been propagating misinformation and providing room for world bodies like the World Health Organization to give bad advice, and providing other governments and people opportunities to provide bad advice and not to follow the right policy. So let's just follow two examples of that. Obviously, we all know that when you put a mask on, the amount of material that comes out when you cough, breathe, sneeze, talk, yell, sing, is reduced. And we know that this virus, the virus that causes SARS-CoV-2, is reduced in terms of its ability to escape from the airways with masking. This is just a nice paper from Nature Medicine showing the amount of virus, 10 to the 8th copies in nasal swabs. When you start looking at what happens when you put a mask on, you can see that this is drastically reduced in terms of what is exhaled. If in addition to that, you wear a mask yourself and the person speaking to you is wearing a mask, the amount of virus you actually are exposed to is massively reduced, and the likelihood of picking up this disease is extremely low. In addition to that, in addition to being less likely to pick up the disease, if you do get the disease, it's clear that the lower the viral inoculum, the less virus you get exposed to, the less likely you are to have severe disease, end up in the hospital, or die. So it's very clear that there are clear advantages to wearing masks. What have we done in the US? We've done a terrible job from the perspective of our political leadership in making a clear statement that this is a way to end the epidemic. And that gave the WHO for a long time, until June, they failed to provide clear guidance that wearing masks in public places is a very good thing to do. Now we're seeing observations from places that have been marginalized like Iran that are looking at virus in the air in places like shopping malls and other places, doing studies that, that really are at the cutting edge that we're not doing here because we don't have the political will to embrace what we know works. Now, what about vaccines? We've heard repetitively that a vaccine is just around the corner. Now, I'm somebody who believes in being upbeat about the opportunities for science to move in the right direction and to help us with solving public health problems. But if you look back at the AIDS epidemic, one of the most destructive things that happened for the first 15 years of the epidemic was the constant optimism from the vaccine community that a vaccine was just around the corner. This led the politicians to think that it wasn't necessary to provide AIDS therapeutics in places like sub-Saharan Africa and other resource-limited settings. It cost hundreds of thousands of lives because they were able to say the vaccine is just around the corner. In the case of the coronavirus outbreak, we've been hearing since the spring, initially it was we'll have a vaccine by the time school opens. And what this has led to is a sense that we don't really need to take this epidemic seriously. It's going to be a short-term problem. We don't need to develop solutions to help us live with this vaccine looking over our shoulders. Are we going to need to do that? Well, let me show you a little bit of data that I think is an important way to think about vaccines in perspective. Now, these are data looking at the evolution of antibodies in the bloodstream of people who are infected with SARS-CoV-2. And you can see that people in green who have asymptomatic infection develop antibodies to the virus, but you can see that people who have more infection, who are symptomatic, have more virus, develop have higher levels of antibodies to the virus during the course of their infection. So one thing that's clear here is the more virus you're exposed to, the more likely you are to make a vigorous immune response. When you're exposed to this virus, there is tons of virus in your lungs. When you get a vaccine, at most we're going to see a minimal amount of viral antigen in your arm, and we're hoping that we can make a response this vigorous. Now, this very vigorous immune response led people to say, well, what we need to do is if we just get everybody infected, but protect the older people. Now, how you do that isn't clear to me. Or protect people who are at risk for other comorbidities that make the disease worse. We will then have herd immunity, and there won't be enough people in the population to have the virus continue to spread. This fantasy has been propagated both within our current administration and by so-called experts who have been cultivated by the politicians leading the country. This cartoon kind of makes the point that by the time you achieve herd immunity, you have so many dead cows that it almost doesn't matter. In the case of SARS-CoV-2 in the US, the estimates are that it would take about 2 million deaths to reach this. And when you reach this, what they fail to take into consideration is that a virus, the immune response to COVID is fleeting. This shows you the same patients who have recovered from their infection, and this is a log scale. You can see the antibody responses are decreasing rapidly. And indeed, about a month ago, we began to see published papers of people who had COVID in the early spring coming back again with new bouts of infection with viruses that are sequenced molecularly and shown to be different viruses. In other words, reinfection can occur as soon as 3 to 6 months after the initial infection. This has got to lead to a lot of skepticism about the wisdom of trying to have COVID parties like the old chickenpox parties. Chickenpox immunity is lifelong. Coronavirus immunity is short-term. The other coronaviruses that we see all the time, that have been in the human population for hundreds of years and cause winter colds, demonstrate that. We have recurrent rounds of infection with this every 3 or 4 years in the human population with viruses that are immunologically almost identical. Now, in terms of the coronavirus vaccine timeline, there are, in general, the way we develop vaccines is the first thing we do is try to figure out what types of immunity that we make during natural infection are important in helping us respond to challenge with the virus. In other words, if we get over an infection and we get exposed to it again, and measure immune responses, which ones are the ones that seem to be present in people who don't get infected the second time around? And that's what we've been trying to understand with HIV for one thing and coronavirus for another. And we don't yet know the answer to that. There is some emerging evidence that it's important to have antibodies, neutralizing antibodies in the bloodstream, but we don't really know how bulletproof that makes you. And we certainly know that they don't last for years. The next thing in vaccine development is try to decide which vaccines might induce the kind of immunity you're looking for. Some vaccine platforms, depending on how you present the antigens, will produce more cellular immune responses, so-called killer T cells. Some will induce antibody responses. And based on what we know about these platforms, begin to do studies in animals that try to see what types of immunity and the potency of the immune responses that are generated by these candidate vaccines. Then we go into human studies, phase 1, 2, and 3. In the early human studies, the first phase 1 studies are in some ways a recapitulation of the animal studies. We take a small number of people who are volunteers, they get the vaccine, we look to see if they develop antibodies, see how well the vaccine is tolerated, and what type of dosage should be used. This often takes 6 months to 2 years with most other vaccines. Then we try to develop the best dose and schedule to get these responses to be the most vigorous in all the populations at risk. For the coronavirus vaccine, we'd want to know whether you want to have what dose to use, whether you need a booster vaccination, whether or not you'd have a different vaccine schedule in older people that we know will not make as vigorous an immune response to the COVID antigens, and whether there is a vaccine strategy that will lead to longer term immunity that would protect people when the vaccine's out there for a longer period of time. Then after the best responses, the best regimen for the most compelling vaccine candidates have been discovered, delineated. We then do the phase 3 studies, which are the ones you've heard most about over the course of the last several months, that take tens of thousands of people, in which you try to see when the rubber hits the road, does this vaccine given in this dose, in this schedule, result in fewer infections or less morbidity, less mortality than people who don't receive the vaccine. And these studies by nature have to be large because the infection, you're counting on natural infection as your output to be able to assess whether the vaccine is working. You have to have enough people exposed over the course of time to see whether or not the vaccine is protective. And where we are right now with coronavirus vaccines is we have a couple of vaccines in phase 3 now, 3 of them, and 2 of them are now on clinical hold because they need to be evaluated from the standpoint of potential side effects. It's likely that these vaccine trials will be restarted. But the point is, none of this is none of this can be counted on like you can count on a physics experiment. Biology is complicated. And the reason this is important is if we have a vaccine that works, protects everybody, young people, old people, 100% of the time, and we're fortunate enough to be able to make hundreds of millions of doses and to vaccinate the entire world, it's going to take a while to get there. We have no way of knowing whether we're going to have a vaccine that is that effective over the short term. Our experience with vaccines in the past has been, it's an iterative process, and the first few vaccines won't be that good. And so what that then means is we have to learn as a society, as a global society, how to live with this virus, basically sitting on our shoulder and looking for opportunities to infect us. And that requires us to approach this in a public health way that limits spread, in a therapeutics way that makes treatments available to people who are particularly at risk for being severely ill, and to recognize that if a vaccine does develop, that's terrific, but we should plan for the worst while we hope for the best. So what is our interim report card? As a final comment here, I think we've done a good job at beginning to develop the framework for vaccine and drug development. And that's something that has happened in academic labs in the private sector and in government laboratories in the US, and hasn't been meaningfully inhibited by the current administration. In fact, in some ways, we have to give them credit for providing ample funding to the NIH and other entities for moving in this direction. We haven't done a good job in public health practices. Local health departments have tried very hard to provide the kind of guidance and advice they need, but they've been getting mixed advice from the CDC, which intrinsically knows what to do, but has been repeatedly held back by the White House task force in terms of giving the advice that they know is correct. In terms of strategic and financial assistance to other countries, F is too high a grade for us to try to claim. And political leadership, likewise, the U.S. has abjectly failed, and really our response to this pandemic domestically has led to a major loss in our international stature and prestige because people see us as being unable to even protect ourselves. So I'll stop there and just make the point that this is really a global problem. We're all in this together. And what's really important is that science matters. We need to be prepared. We have to approach things in a competent way. And it's important to be transparent and honest with our response to this disease and all others that we're going to see coming down the road. So I'll stop there and look forward to hearing from the other panelists and having a discussion with other people.
Thank you very much, Chip, for sharing that knowledge and presenting us with that critical and sobering picture. We have just heard some important epidemiological, public health, vaccine development perspectives from Dr. Schooley. We are now going to switch gears and go to an on-the-ground clinical perspective from physicians who are on the front lines working in a population that has been severely affected, that is the Native American population, and in particular, the Navajo Nation. Our next speakers are Dr. Mia Lozada and Dr. Jenny Way. Dr. Lozada and Dr. Way have both worked at the Gallup Indian Medical Center of the Indian Health Service in New Mexico since August of 2012. Dr. Lozada is a general internist working both in primary care and in the ICU settings. Dr. Way works half of her clinical time on the inpatient side, also working with the ICU, and half in the outpatient primary care clinic, which includes a transgender clinic. Both Dr. Lozada and Dr. Way are assistant clinical professors at UC San Francisco and have been directly involved with the response to COVID-19 in the Navajo Nation and in Gallup, New Mexico. I, as some of you know, spent many years doing research on healing in the Navajo Nation. And I recently encountered Dr. Lozada and Dr. Wei via a webinar that was sponsored in part by Partners in Health. And I heard them talk about their experiences in Gallup and working with Navajo people. And practically the first thought I had was, we have to recruit them to come to one of our quarterly conversations. I'm so pleased that they have agreed to join us. So join me in welcoming Dr. Mia Lozada and Dr. Jenny Wei.
Thank you very much. We are thrilled to be here and are so impressed by what we've seen thus far. This is such an incredible forum to bring together so many different organizations and people. And we're really excited to share our experience here regarding COVID-19 in the context of specifically more vulnerable, or populations that have been made more vulnerable, with the specific example of those experiencing homelessness. So what we'll want to discuss today are summarizing some of the events that have happened here in Gallup, New Mexico, and give you a little background about what our environment is like here, for those of you who may not be familiar, and that might be most of you. And we'll talk about a new model that we kind of had to develop out of force to try to help to house or isolate and quarantine many unsheltered individuals, particularly those with substance use disorder in the context of COVID-19 and a large outbreak that we had here. And in collaboration with our primary workplace, which is the Indian Health Service here in Gallup, New Mexico. So Gallup, New Mexico is located at that red circle near the Four Corners region of the Southwest. We're about 25 miles from the Arizona border, and our town is about 20,000 people. You can see here the areas that are all highlighted are Navajo Nation, sectioned into different, essentially states as an equivalent of what we have for the United States. And the entire area here is Navajo Nation, with the exception of that beige area, which is Hopi Nation, which is one of the Pueblo tribes, which is embedded within the Navajo Nation. The Navajo Nation spans about 27,000 square miles. It's about the size of South Carolina. It's extremely large. And so you can imagine how there's just tremendous expanse in this area. Our area, the circled in red, Gallup, New Mexico, has what we call checkerboard area in terms of reservation land within the city of Gallup, which is a city in New Mexico. We have frequently changing areas that go from reservation to non-reservation land within our community here. We're also the most patriotic small town in America. So
it's important to vote. We voted for that in 2013 and we got it. So voting matters.
We have a large veteran population here. Many Navajo have served in the armed forces as well. So Navajo Nation, each Native American tribe decides its own criteria for membership, and the federal government decides to respect whatever each tribe has decided. So for Navajo Nation, it amounts to about 300,000, a little bit more members of the Dene tribe, about half of whom live on the reservation itself here in the Southwest. For Navajo, the requirement is about a quarter blood quantum. For general demographic information, the age of those living on the reservation here, the Navajo reservation, is significantly lower than US all races, and overall the household income medium is significantly lower. Those living under 100% of the federal poverty line, more than twice as high. The unemployment rate here on the reservation is upwards of 50%. When we're talking for US unemployment rates and how it goes up to 7, 8, 10%, that is just unheard of. 50%, you can imagine how staggering that is for a community, a population in terms of economic sustainability. And for context, Gallup Indian Medical Center, which is where we work, which is an Indian Health Service site, we have two different buildings. The one on top is our outpatient building. The one below is our inpatient facility, which was built at the time the Gallup Indian Medical Center was founded back in 1961. IHS was founded around 1955. So we have a lot of general specialties for those of you familiar with the medical portion of things, internal medicine, family medicine, pediatrics, but we really lack a lot of subspecialists. So when you come to a disease like COVID, where people are having significant cardiac or kidney problems or lung problems or need intensive care, we lack a lot of those subspecialists. And so the entire premise of care for Indian Health Service in these more rural sites is really trying to become the specialist as best you can for your patients. Our location is about 120 miles from the largest tertiary care facility, which would be in Albuquerque. So that's a 2-hour drive. Or which can be really challenging when a patient is very sick in terms of getting them expedited care to another facility. So we try, and in COVID have really tried to ramp up as much as we can provide our patients in this setting here. And this is just some general information about what we do, as discussed, a mix of inpatient and outpatient medicine. So more specifically, what happened in Gallup, if you looked back at the New York Times about 2 months ago, we were still top of the places hardest hit by COVID in per capita cases in the entire country. And in terms of the number of total deaths per capita. Thankfully, in the last couple of weeks, we've been knocked down, but that simply means that there's a community that has been harder hit than us now. And those numbers are just worsening across the country. As you can imagine, we're down to number 4 or 5, depending on the day now. So specifically, you can see the number of cases in each of these state equivalents across Navajo Nation. The total for Navajo Nation, which is itself a sovereign nation, has 10,000 cases as of the data that came in yesterday. So Navajo Nation and COVID, what are the things that contributed to the cases being so incredibly high? Many times people are focusing on the lack of running water and the lack of services, just pure, structural, infrastructural needs. The Navajo Nation, about 1/3 of patients, of individuals who live on the Navajo Nation lack running water and electricity. When the main public health message is to wash your hands for 20 seconds and you don't actually have running water, it is exceedingly hard to do that. When there were, alcohol-based sanitizer shortages across the country, that was really, really hard for many of our patients. They didn't actually have the means to keep themselves safe in the simplest way. The Navajo Nation is a food desert, and so people take large trips far away and are having to make these big kind of outings far away from their homes, potentially getting exposed in other areas in larger cities like our own, and bringing it, disease back to their more rural settings. Shelter in place, which was touted as being something so important to do, stay home as much as possible, is a privilege if you don't actually have a shelter to shelter in place in. And I know this is something that has been highlighted across the country, particularly for individuals who are experiencing homelessness at baseline. This posed, and we'll talk more about this in a moment, posed significant challenges. Shelter in place, when we have many of the individuals living on Navajo Nation who rely on going into surrounding towns for a lot of supplies for their animals, these are big sacrifices that they have to take. I remember talking with many families when we were saying, when we say stay home, what does that mean? And because many family units are all surrounding, like within a 1-mile radius, many of my patients would tell me, well, that still means I can go to grandma's house. That still means I can go to my auntie's house, that's about 200 feet away. And so many family clusters were happening because the definition of home for some cultures, for some families, is very different than what my definition of home may be. I think there's, as referencing to the lecturer before us, there has always been an undercurrent of mistrust of the federal government because of profound historical trauma that has happened to our Native and Indigenous communities. And so many of the messages coming out from the government and from other entities, IHS included, have the potential to not be trusted at face value initially. And so that is something that we are very cautious with in terms of interacting with and trying to mitigate the continued spread of the virus. And so what happened at our hospital? This was what our emergency room looked like pre-COVID. And very rapidly, we made so many significant changes, creating these essential, bubbles for each of the patients in each of the rooms that they were being seen. We did all these tremendous changes and not much happened. And then we had some significant numbers kind of uptick over the course of March and April. I want to end with, for my portion of things, with these next couple slides talking about the more positive aspects of what has happened with Navajo Nation in the tremendous burden of cases that we've had. I want to talk about some of those positive things as well. So Indian Health Service, we were fortunate in our kind of federal capacity and connection to be able to get access to a lot of rapid testing. Many sites across the country who are battling with, tests turning around in 2 to 3 days, and we were very lucky to have access to both Abbott and Cepheid testing that would return in a matter of minutes to hours, which impacted our ability to do case investigation and contact tracing more rapidly. We'll talk more about our hotel motel program for isolation. We were transferring out probably the highest number of intensive care patients from our region of the state as compared to any other part of the state for higher levels of care, for ICU care at the peak of the pandemic for us in April and May. And we were lucky to have a coordinated effort with the state. Navajo Nation, the tribe itself, did a tremendous job of doing a lot of pretty aggressive public health measures to try to bring the case numbers down. So they instituted weekend lockdowns where people were not allowed to leave more than a mile away from their home residence from Friday evening to Monday morning. And this was majority of the spring and summer. It let up, and then now as cases are starting to uptick again, it is back in effect. Extremely wide testing. So if you look at the numbers of tests that the Navajo Nation have tried to spread over IHS and encourage individuals to get tested, even with very, very, very questionable mild symptoms, about 56% of the population living on the reservation have been tested. I mean, just tremendous numbers in terms of trying to get the numbers down. And a shared contact tracing system throughout all of Navajo Nation as well. It got the Fauci stamp of approval in a lecture that was done with Dr. Fauci and Navajo Nation, where he said, the reason you should be proud of what you've accomplished is that you've proven that when you do these public health measures, you can turn around a serious surge of infection. So showing that if we do follow some of these simple ideas that can be harder to actually carry out, they do work. And my patients have continued to remind me to really focus on the beauty. Over the course of the spring, there were tremendous, not necessarily negative, but highlighting a lot of the burden of the experience here in the Southwest among the Navajo population. And my patients would say things like, that's just not who we are, that there are tremendous stories of resilience and power and beautiful, interconnected and woven families and deep culture and remembering how valuable and important that is and how that in and of itself, having messages about wear your mask to protect your grandma means something because of that culture. And now Jenny will share a little bit more about our homeless experience in terms of caring for those who have been made more vulnerable by lack of housing.
Great, and thank you so much again for inviting us. It's truly an honor to be able to be here, and it's just incredible what you guys at UCSD have put together in terms of the global health community. So it's great to be a part, if even just for a little bit. So as mentioned, I work at the Gallup Indian Medical Center as well. I have a particular interest in substance use disorders and alcohol use disorders. So, and one of my roles as well was chair of our McKinley County Task Force, Alcohol Task Force. And a lot of what I'm going to talk about today kind of stems from just being a part of that task force. It's hard to talk about the context of the outbreak here in Gallup and on the Navajo Reservation without sharing a little bit about alcohol-related deaths in the United States. Unfortunately, this is not a list of which you want to be at the top of either. For over 2 decades now, New Mexico has had the highest rate of alcohol-related deaths of any state in the U.S. So I just want you guys to keep these numbers in mind. This is 27.9 per 100,000 deaths in the U.S. on average. In New Mexico, that number is 51. over per 100,000. And now as we kind of look at the specific counties in New Mexico, we are in McKinley County, which is right on the border of Arizona on the west side of the state. And you can see in McKinley County, 166 per 100,000 deaths. We are the county with the highest number of alcohol-related deaths of the whole state of New Mexico. And unfortunately, as probably expected, American Indians and Alaska Natives bore the highest rates at 170 per 100,000. Now, this has been a struggle for decades and decades and decades. And early in the 1990s, we advocated to the state to protect people who were suffering from alcohol use disorders because so many people were dying of exposure-related deaths. Not a term that we're very proud of, but back in the 1990s, we were called Drunk Town, USA. And so New Mexico did pass a law that's called the Detox Reform Act, which allowed us to put people under protective custody for 12 to 72 hours if they were a harm to themselves or others. So we have a very large detox and sobering center here in Gallup, which has helped with exposure deaths, but I think obviously there's some mixed feelings about the detox center overall. Unfortunately, as we were planning for this pandemic, the detox facility, along with our shelter program and along with a few other congregate settings, were really a large focus of us because we knew that if we were to be hit with COVID, that these facilities would be disproportionately hit and there could be an outbreak. So very early on in our planning, starting, early in late February, early March, our task force got together and we started thinking about what would happen if our patients were no longer able to go to the detox facility because everything had to be cut down 50%. We knew our hospitals would be overly burdened, our emergency departments would be overflowing if we weren't able to get people safely to detox or to a safe place where they could isolate if they don't have housing. So we thought about multiple ways of trying to get people safely isolated where they could, wait for their COVID test results, where they could isolate and quarantine. We thought about churches, schools, recreation centers, putting up outdoor tents with portable latrines and heating sources. And right around this time as we're talking, I remember Mia talked about how she got a phone call from the emergency department. And one of her patients who previously was staying at the congregate shelter setting in town had some symptoms and was awaiting a test result. And there was no place for this patient to go. And a lot of us just put together some money and said, well, let's just pay for a hotel room. And we started thinking what we really need are many small units. And of course, around this time, the tourism industry was really suffering. And so with the help of an incredible community support, many volunteers started calling all the hotels in town in Albuquerque. And I'm still so thankful. I'm just thinking about all that was unknown back in March and April, that one of the hotels was brave enough and willing to work with us to house actively COVID positive people. For us, our very first case was on March 18th at Gallup Indian Medical Center and was the first case in the whole county. Very quickly after that, with all of this planning happening, we were able to set up the isolation shelter at a hotel called the El Rancho. If you're ever in town, give us a ring. We'll get you a hotel room at the El Rancho. That's not meant to be. That's not meant to be a joke. They do a great job cleaning. Anyway, so. And what did we provide? What were we able to put together to provide in these isolation hotels, recognizing that people had to be there for 10, 14, 20, maybe even longer isolating without leaving, of course. So that's the key. So some of the things that we thought about are making sure that meals were provided, 3 meals a day were provided. Some buddies of ours in town who were also probably the bravest people that I know were willing to outfit their car and transport active COVID positive people back and forth from the hospital to the hotels. It was an incredible collaboration with COPE, and COPE is a Partners in Health program. It's the only domestic Partners in Health program based in Navajo Nation, and that's what was mentioned. And I'm so glad that you were able to be on that phone call, on that webinar. And COPE has been incredible. Not only have they received tons of donations for clothing and snacks and puzzles and radios and anything to try to keep people entertained, refrigerators because people needed to be on insulin and some of the hotel rooms didn't have refrigerators. Not only that, but they helped triage all of these needs. And then if there were anything medically related, they would direct them to our medical oversight program. And it was incredible the amount of people that we were able to recruit to help us in on our teams. We joke that we've been working on trying to get patient-centered medical home status in our hospitals here and in our clinics here. We haven't quite been able to do that yet, but we feel like that was our goal at the hotels. So we not only did people from all over the hospital volunteer, we even had people come out of retirement to help us. And we also had over 40 people from all over the country. I will say many from California coming to help us, nurses, doctors, respiratory therapists, tons of people going outside their scope to kind of be part of this isolation team, going and checking in on patients daily to make sure that their COVID symptoms were stable, that their oxygen levels weren't too low. But not only were we able to address people's acute medical issues, we were able to, for the first time, start to talk about the chronic medical issues that they were never able to address because they didn't have their basic needs of housing and safety met. Over the course of the program, I'll tell you a little bit more about how many people we were able to house in the program, but we probably up till now, over 7,000 hours of donated time have been provided to this program. And I just am so humbled and so grateful to think about all of the volunteers that have come through our program here. And certified peer support workers, obviously if people are in isolation and suffering from substance use and mental health and not having their coping mechanisms that they usually rely on, it was really important to have peer support workers calling them. Also very lucky to have Native medicine, Navajo interpreters, chaplains available as well. I'm sitting here in our headquarters where I smell sage, which is a Native medicine that our Office of Native Medicine has provided us, and it's been incredible to be able to, oh, Mia's gonna go get some for you. This stuff, I wish this was smell TV. This is just amazing. And so when we actually offered it to our patients in the hotels, many of them cry. They're like, this is so expensive, and the fact that it's been blessed by a medicine man is incredible. So I am incredibly proud of the support of the community to come together. We also had 70 iPads donated, and so we were able to do telemedicine sessions, group sessions with Alcoholics Anonymous, NA groups, which were also really, really great for support. So I am unfortunately foreshadowing that we have this program all together. We have about maybe a dozen patients by early April, and then unfortunately, as our worst nightmare had predicted, our detox facility, an index case tested positive. And when we looked back, he had spent 3 of the last 7 days in the detox facility, exposing over 170 patients. And ultimately, when we looked at all of those patients during the brief couple weeks after we were contact tracing, 75% of them were positive. And that's an incredibly high number, even considering a congregate setting. So unfortunately, a detox facility like what we had set up was just a horrible or a great way of spreading COVID. By late April, early May, and all the way through June, we had increased to 4 motels, daily census of about 140 to 150 people. Over the course, since March 24th until today, the program is still running. Now, thankfully, we only have about 10 or 12 patients in the program right now that need an isolation or quarantine place. But since March 24th, we've had over 950 people in the program. And as I was saying, we were able to address their acute COVID issues, transfer them back and forth to the hospital, et cetera, when needed. But we also, over the course of time, were able to get people, over 30 people into alcohol treatment programs. We're able to connect people back, get them IDs, get them starting to apply for jobs, have them reconnect with family. Some people had not seen family in over 4 years, and they said that for the first time. I remember seeing a patient and I complimented his mask, and he's like, yeah, my mom made that for me. It's the first time I've talked to her in over 4 years because I'm finally sober and I can actually start to focus on some treatment that I need. So I hope that this program shows that housing first is not only the right thing to do. What we see is that when you actually provide people with their basic necessities, they can start to move towards their goals of applying for a job and starting to get their chronic medications in order and starting to get their substance use treated. Not only is it the right thing to do, but it saves precious resources during this time where all of our other resources were being used to the max. Our emergency departments were full, our detox facilities, the police department. In this particular population, we saw that there were significantly decreased emergency department visits, significantly decreased time needing to go back and forth to rehab, et cetera, back and forth to detox, and less run-ins, fewer run-ins with the law. And so I'm hopeful, of course, none of us are very thankful that COVID ever hit us, but I'm hopeful that this type of program shows that people who are the most vulnerable unfortunately can lead to outbreaks like this, and it's a public health emergency, and a public health homelessness is a public health emergency, and housing is preventative medicine. And so I really hope, and we continue to work with the county, the city, and the state to advocate for transitional housing and permanent supportive housing options. And I think this program has really shown how important that is. As Mia mentioned, my patients always say, please, please focus on the positive as well, focus on the beauty and the resilience of our people. And these are just some pictures that some of our patients have. This is at the Howard Johnson, and it was just beautiful to see all of the artwork that was outside each patient's room. This is one in particular, patient who actually drew with pencil and made this for one of our volunteers who came from California. Ahiahe means thank you in Navajo. And finally, I just want to end with a letter that one of our patients wrote to us in the program right before he was leaving. And he said, I'm writing to you not just for myself, but for others also, thanking you and your first responders. They are doing a great job checking our temperature and other medical conditions we have. I've been put in this motel room by myself. At first I thought it was okay, then I wanted to leave because I have an addiction problem. And some of your first responders have helped me by talking to me, setting me up with a treatment center, or I should say a healing center to get rid of my addiction. I'm healing from this poison and other poisons. I just would like to say thank you and your responders. So all I'll say is that it's been an incredibly amazing collaboration with not only the Indian Health Service, but Partners in Health and the Community Outreach Program, Navajo Nation, the private hospital in town, the detox facility, all the volunteers, city and the county, the state. And it does really seem intimidating to look at this list, to think how could we possibly all come together to respond to an emergency like this. But I think it really just is a matter of relationships and knowing that one person from that one organization to be able to do it. And again, I'm just so appreciative of everyone's willingness to help us in this small town in Gallup. So I hope we didn't go over time, but thank you so much for having us be here.
Thank you very much, Dr. Way and Dr. Lozada. I'm going to take you up on that booking at El Rancho. Please get me the Humphrey Bogart room.
That's right. That's right.
It's quite interesting that we're operating here under a comparable situation. We've been thinking in terms of the phrase "a crisis within a crisis." Our work here is with refugees and asylum seekers on the border, many of whom are right now, because of the migrant protections protocols, stuck on the Mexico side, and the refugee crisis has now within it a crisis of COVID, and people are working up similarly to what you've had in setting up quarantine hotels, what they call filter hotels, and the Tijuana General Hospital has entirely become a COVID hospital. No other kinds of patients are being treated. So what you described is a crisis within a crisis within a crisis, because you have the ongoing weakness of availability to health resources in the Navajo Nation. And then within that, the crisis of alcohol abuse and within that, the crisis of COVID-19. So I'm sure I can speak to everyone who's online that we admire your work and are quite pleased that you have consented to be with us today. Our final speaker is Dr. Timothy Stenzel. Dr. Stenzel directs the FDA's Office of In Vitro Diagnostics and Radiological Health and has an extensive background spanning more than 20 years in executive leadership, innovation, companion diagnostics, research and development, FDA regulations, and clinical laboratory operations. So we're moving from where we started in the epidemiological realm to the clinical realm, and now to the realm that's relevant very much to global health policy. And I must also say that Dr. Stenzel is himself a part of our, literally part of our global health family, with his own family connections to our own racial brand. And so with that, I would like to welcome Dr. Tim Stenzel.
Thank you so much. Hopefully you can hear me okay. Yeah, it's great to be here today, part of this program. And I do have to give a shout out to Rachel, a member of our family who approached me about participating. I also have two other really awesome and cool daughters. One of them may be listening today as she signed up. She's on staff at Duke University as a physician assistant. Anyways, a little bit about my background. I am relatively new to the FDA, even though it's been 2.5 years. There's so much to learn about the FDA and so much to learn about the U.S. government and how it operates. Certainly when I signed up in summer of 2018, I had no idea we were going to be having anything like this happen to our country or to the world. It is our office's, the one I lead, responsibility to review all diagnostic submissions that come to the FDA, essentially all. There's a few tests that go to the Center for Biologics. Anything having to do with blood testing for donation goes there. Most everything else comes to our office. And our office consists of about 300 people, all scientists. But the group that is responsible for virology, those applications having to do with the detection of viruses, numbers about 25 people. So that's the size of our office as it's applied to respiratory viruses and other viruses that cause disease. And so it's a small but very expert group. Anyways, my background lent itself good for this role because I had experience both in clinical labs as well as in companies that developed diagnostic tests. Anyways, to give a brief history of the pandemic from our perspective, from the FDA's perspective, in very early January, the CDC and the FDA communicated about an outbreak in China. We were very concerned about it and quickly came to the determination that this was a potential emergency that could impact the United States. And so the FDA and the CDC worked closely from that day all the way through to today. And we activated the various U.S. government agencies that are involved in emergency preparedness. That involves institutions like the CDC, of course, CMS, Centers for Medicaid and Medicare Services, as well as NIH. We began our pre-planned operations for any such emergency at that time. Of course, we have a fair amount of history of working together already. This is not something that we pulled together just this year. But you've heard of H1N1, you've heard of perhaps of an enterovirus outbreak. You've certainly heard of Zika virus as well as Ebola. Those were all previous emergencies. They're, in fact, all continue to be declared emergencies even to today. And most have tests that have been authorized by the FDA, and those are ongoing. And of course, predating those emergencies were the emergencies involving the first SARS in the early 2000s. I had the opportunity to visit Toronto, Canada, in the midst of that pandemic. They were the center of the North America outbreaks for SARS. I visited the labs there that were doing that work. So my experiences with working with global health crises is approximately a little bit under 2 decades. And so all of that has come to bear along with all of our experts within our office and within the FDA. The other one was, I'm blanking on the name right now. I'll come back to that. A little bit more about what happened in the beginning of this year as we began to address this current crisis, an ongoing crisis, is that we called together the agencies that are involved with emergency preparation. We began planning for it. One of the things the FDA does, has done in previous emergency situations, is that we begin an outreach effort to developers. This includes laboratories, test developers, and other groups that can come to bear to address the needs for testing. And so we put together recommendations of how you might develop and validate a test that was made available to all these various groups, both and to national groups that could distribute it to their membership. Of course, the CDC was working on their own test. From about mid-January through February 3rd, they were working on the development and validation of that test. The FDA received the CDC's test development data on Monday, February 3rd. I know because I was hosting at the FDA an emergency preparation conference, an all-day conference that included all those U.S. government agencies. Also, a little known, actually very well known, group was in attendance, and that's the Gates Foundation. Was pleased that they were there because from that day forward, we have began a partnership with not only the Gates Foundation that has yielded some really interesting work, but other groups as well who were there that day. But anyways, I was in that meeting, got word that the CDC's data had arrived. The other members of our office who were at the meeting, there were just 2 others, they immediately went back to the office and began work on the review. And a day later, on February 4th, the CDC's test was authorized. That immediately made available kits that the CDC has developed to more than 100 public health labs across the U.S. And so at that point in time, we thought that we were in pretty good shape because we didn't know quite how big this pandemic would be. Yet we did not rest at that point. We continued our work at the FDA. And by the end of February, there were 10 labs that were doing testing in the United States. And that also included 2 companies that were developing and that had developed and were producing kits. Again, we were feeling reasonably good about that opportunity, but the pandemic really grew. And we continued our efforts, and by the beginning of April, working with various test developers, we had produced in the United States 40 million test reactions, and they were available for sale. Now, at that point, we realized that the testing needs far outstripped the lab testing capacity in the United States, and also began to present problems having to do with reagent and supply availability. So the FDA, even though it's not in its purview, began to address shortages of all these components to do our part. So to date, the FDA has received, including both pre-submissions and submissions, over 2,400 EUA test submissions. We have authorized nearly 300 tests, and we have authorized more than 200 amendments to those tests. At the same time, we have denied about 100 tests EUA authorization. That is based on performance of those tests. So the pass rate at the FDA for submissions is somewhere around 75%. About just under 300 tests authorized and about 100 tests denied those authorizations. So that was a little bit eye-opening to us that so many tests would fail to meet our expectations. On the other hand, the number of tests we've authorized to date have far exceeded all the other previous emergency situations combined. So obviously this is hopefully a once-in-a-lifetime situation, once-in-a-100-year situation, and we don't see it again for a very long time. But it certainly is unprecedented in its scope and its impact on patients. So I'd also like to talk about the center in which our office sits. So our center is the Center for Devices at the FDA. In addition to those EUAs that we have received, the center itself has received almost 5,000 submissions and has authorized, and this is of last month, over 500 medical devices. We have reached out to more than 1,000 manufacturers in this pandemic. We have collaborated with more than 12 countries. We have sent our own, we have an officer corps, and we have sent 58 of our officers out into the field deployed to assist in COVID-19 missions. Our center has received more than 300,000 emails and phone inquiries that we've rapidly responded to. We have given more than 40 seminars to more than 36,000 participants. I myself have hosted more than 30 of those webinars for more than 30,000 participants. I host a weekly webinar for developers and address their questions in real time in order to speed our response to them. I think it's important, even in the midst of such an emergency, to take time to determine if you were to do this again, would you apply any lessons learned? And we do that almost on a daily basis as we address the ongoing and growing and changing needs of this pandemic. But we also do that for the next time so that we're even better prepared. So Dr. Shuren, who heads up our center, and I published 2 articles last month, one in The Hill and one in the New England Journal of Medicine. The first one in The Hill addressed a developing need, and that is to further greatly expand testing in the United States. So we would like to see testing available in every home in the near future. And we are working with a number of developers. That piece in The Hill was addressed the urgent need of home testing. It also let people know what we expected to see in the performance of those tests. It also addressed our desire to be as flexible as possible, as long as the science supported what the submissions offered, and so that we can give a positive decision for those submissions. In the New England Journal of Medicine piece, we addressed what we thought to date were the lessons learned. First of all, to remain flexible and adaptable to the ongoing pandemic and the situation. And as I said, we evaluate this on a daily basis. I meet with our small team 3 times a day for quick meetings to address any immediate needs and to adjust what we're doing. We meet as a center multiple times a week. I brief not only the center director, but the head of the FDA and members of the White House Task Force on Testing as well. What we've learned in the early parts of this pandemic, even all the way through February, is there was almost no samples available, patient samples available in the United States in which to either develop or validate the test. So what we learned is that we really need an international effort to acquire, bank, and share samples that can be used worldwide. Next time, it may be that an outbreak starts in the United States, and we want to do our part to help the rest of the world. This time, the outbreak did not start in the United States, and we just did not have access to those samples. And what we did is we had access to one of the first samples in the United States. We sent that sample for culture at the CDC. The CDC then handed that culture over to NIH and a contractor with the NIH who grew that up in a BSL-3 facility and made that material available to developers by mid-February so that they could develop their tests. The second thing is, as I said, we've authorized now almost 300 tests. We would like to focus on a system that could focus on a smaller number of very high throughput tests that could be deployed easily and manufactured in the tens of millions in very short order, that could be deployed throughout the United States in appropriate labs that had common equipment. We think that kind of preparedness would allow us to get much higher throughput testing more quickly should there ever be a need such as this again. And then we would follow with providing point of care testing in clinics, in reservations, in hospitals that don't have the access to the kind of testing that some of the labs do. And then also for home testing so that individuals could test in their own home and know if they have it or not and could guide their own decisions. And then third, we found out through this pandemic that those who utilize the tests that the FDA has authorized sometimes do not understand enough details of the testing in order to interpret that properly. I think we've seen this very recently in the press. You probably have read about supposed false positives in nursing homes, which the government acquired and distributed many of these point of care tests in nursing home across the country. It's important to know that over 1,000 patients in nursing homes a week die and have died every week of this pandemic that has fluctuated to as high as 4,000 nursing home patients a week. So it's very important that we protect the most vulnerable of our citizens. And I believe that the agent, and especially those in nursing homes, are some of the most vulnerable in our country. So you probably have read about supposed false positives. Really, to our date, our investigations have not yielded a problem with any of the tests and their performance. It's simply that, that we've done a good job at this point in protecting our senior citizens in nursing homes, and the number of true positive cases of COVID in those nursing homes right now is very small. And even if you have a very, very good test, you can have false positives. That's just statistics. And when those false positives, due to no problem with the test itself, we're talking about at maximum 1% false positives. But if the percentage of patients who are true positives are less than 1%, then it's going to look like there's a problem. Our investigations to date have said that this really works. And the CDC has even come out with guidance prior to this that has said that when you get a positive result with any test in such a low prevalence population, you should verify it with another test. And we think that if we do this, We'll quickly resolve this concern among all involved in this kind of testing. We can put that concern to rest, and we can best protect those most vulnerable, our senior citizens. And so with that, it kind of ends the portion of my prepared remarks, and I'm happy to take any questions when that time comes.
Thank you very much, Dr. Stenzel, and thanks to all of our speakers. We'll now move on to a brief question and answer session for our panelists, and would like to open it up to the audience to ask questions. You'll see at the bottom of your screen there is a place called Q&A where if you click on that tab, you can ask questions. Please type your questions in there. And as you're typing, we want to let you know that the extra credit Google form for global health students has been posted in the chat if you're receiving extra credit for this event. And those of you who are global health students, we invite you following question and answer to join us for the information session on the Masters of Arts in Global Health program, which will be on this link. You don't have to sign on and sign off again. On to questions. Our first question comes from Professor Janice Jenkins, who is a professor in our anthropology department and our Department of Psychiatry. She says, "This is a wonderful presentation. Thank you so much for the work you are doing." She has a question for Drs. Wei and Lozada, and that is, in the Gallup area, have you observed interactive effects of indigenous activism and protests or uprisings with racism and patient experience and effects of COVID? Interactive effects of indigenous activism, racism, and patient experiences and effects of COVID.
Would Professor Jenkins be able to clarify the question a little bit more? Are they still around? Or are they not able to speak? Is it just us?
I think that we can only...
We can only project, okay.
We can only take, yeah, we can only take written questions.
Sure, so I think I'm not exactly getting the question, so I apologize if we're misdirecting our answer. But there have been a lot of kind of activism and work done on the reservation in terms of trying to increase the voice of the Indigenous, Native American, Navajo experience, particularly in regards to the COVID pandemic and how it's spread so kind of dramatically here in our region. I think there continues to be, you know, a lot of acknowledgement now, more so I would say than previous and prior, that the ways in which structural racism has contributed to, you know, longstanding chronic health conditions within the Navajo community. And so I think when quotes are made stating that, you know, it's higher rates of obesity and higher rates of diabetes and higher rates of asthma or whatever it may be that have made individuals more vulnerable to contracting COVID in the first place and having severe disease courses, there's more of a highlight now about how that's not where the conversation should end. That's a jumping point to try to figure out, you know, what are the structural reasons behind why these chronic diseases are so much higher within this population. And so more and more is being discussed about that now and trying to go more to the root cause rather than just blaming an individual per se for having an elevated BMI. That's really not where the conversation should end.
Have you encountered the issue of racism firsthand in your lived experience as physicians treating the Navajo people?
In terms of, I think what we asking our patients, what their experience has been, time and time again, they have stories about how they have been discriminated against or have had challenging interactions, whether it be within the Gallup community or within a healthcare system. So I think that is something that is definitely at the forefront of our patients' minds, and it's something that we are trying to be as cognizant of as possible. More and more as discussions are happening about trying to not categorize folks simply because of their race and their health conditions. That Native Americans are at blank risk higher. We need to be thinking more about the specifics of the individuals and their individual risks, but at the same time balancing, how society does perceive these individuals as a dedicated race, as defined by our federal government, and how that needs to impact our care.
Thanks very much. Professor Jenkins is here, and she typed in that addresses her question
Thank
precisely.
Okay.
Yes. This next question is for Dr. Stenzel. Can you comment on where we are at in terms of vaccine development? And perhaps Dr. Schooley can also comment on that, since he's also addressed the issue of vaccine development.
Yeah, I'm happy. This is Tim. I'm happy to try to answer that. It's not my area, but we do interact very extensively with the group that reviews vaccines. We work closely with them. But right now there are numerous clinical trials going on. And when those clinical trials have reached an endpoint where the vaccine developer and the FDA feel like they can take a look at the data and make a decision, then those will be assessed. And obviously, we're very eager to see vaccines developed and prove themselves worthy for authorization and then make them available. But that's just my perspective.
Well, I think it's really important to realize that vaccines are an urgent need in this epidemic. We really need a great vaccine. We also need the public to have trust in the vaccine and the vaccines that are developed. So it's really important for the vaccines to be developed with the kind of rigorous information that you heard about from Dr. Stenzel in terms of understanding diagnostic devices, and that the public understand that the independent people have looked at the data and feel that the data are solid and can assure the public, based on the data submitted, that the vaccines are as safe and effective as possible. You have to both develop a product, and you also have to make sure people have confidence in the product to have it used, and the FDA plays a major role in that.
Thanks very much. That question was from Kashish Nizami. We have a question from Ria Shah. Are there any specific resources you've noticed that are particularly helpful to folks experiencing homelessness? I think this is probably directed to our Indian Health Service physicians.
Yeah, that's a great question. I think I am a firm believer that housing is preventative medicine, as I mentioned before. But what's been so fascinating in trying to get people more stable housing is that it requires them to have an ID, is that it requires them to have certain certain of those things that have all been taken away. Unfortunately, many of our folks who are experiencing homelessness also do have comorbid substance use disorder issues. And so certainly making sure that they're getting a lot of those treatments as well, so that things are more stable. But it's incredible how hard it has been to get people IDs, especially in time of COVID, because without an ID, we can't really help them with an application for a job or for other supportive housing programs. So I think that has definitely been a specific program. We also were able to access free cell phones for people. Obviously impossible to actually access these resources without having a way for us to contact them once we were able to set people up with certain applications and things. Other thoughts?
No, that's great.
Okay, great, great. This is also for you, I believe, from Rachel Soretsky. How often do you integrate traditional healing as part of your biomedical treatments for patients in the Navajo Nation? And what does this typically, my screen is jumping, what does this typically look like, and what are the benefits to the community? We got a intriguing preview of that when you showed the sage.
Yeah, it's actually been amazing. Most places on Navajo Nation now, most service units have an Office of Native Medicine, which is really incredible. So, and just as there's a consult in the electronic health record for the ear, nose, and throat doctor or the, OBGYN, there is an electronic health consult for Office of Native Medicine. So I really think about this for my patients who maybe have missed a few appointments, or I'm sensing that there might be, or not adhering to medications. And I always offer this just this consult sort of just like I would other consults that I think might be helpful for patients. There certainly is a wide spectrum of adoption of Native medicine. Some people are some people embrace it, and some people are very much like, I don't believe in that, in those types of things. So I think just making sure people know that it's available to them. I love our working closely with our Office of Native Medicine, because the medicine man will very much say, it's important for you to take the medications that Dr. Wei has prescribed for your diabetes, and we will be able to provide a healing ceremony for you for the disruption of harmony that might also be contributing to your illness. So I really love working here and being able to see us work so closely with the Office of Native Medicine.
So while we're with you, we have one more for you from Brenda Wilson. She talks about having taught the importance of addressing social determinants of health to medical students, where the reception is mixed, with some students feeling that dealing with the social is not part of their job. The question is then, how did you both become interested in addressing the issue of homelessness and policy issues, and what advice would you give to other medical students about their role in addressing this and other social determinants?
I think this is a great question. I think I was lucky enough to be exposed to more multidisciplinary care and different types of models and organizations earlier on in my training. So in college, I worked with an organization called Project Health, which is now called Health Leads, whereas college students, we essentially were working as social workers at a county hospital in Boston. And the example was shared with me very early on that as a doctor, if someone has asthma, you can prescribe them an albuterol inhaler. But if they don't actually have, the insurance to be able to get that medication filled, or they don't have transportation to get to and from the pharmacy, or they finally get that medication, but it's actually the roach infestation in their apartment that's causing the act up of their asthma on a chronic basis, or, like all of these other factors. So as a doctor, I was pre-med and I really wanted to pursue medicine. And the message was kind of drilled home to me that as a doctor, my role was to prescribe that medication, but I was then dependent on so many other factors falling into place for that patient to actually succeed with that specific medical condition. And so that example, I think, was so powerful for me, recognizing, one, that it is truly a multidisciplinary specialty. And it made me want to go into social work. So maybe that's part of, being a doctor was kind of my second life plan. But two, you also have to think of the doctor role as being a very small role in all of it, when in actuality, life happens far more off the planned trajectory that you may have outlined for your patient. And so you need to recognize those things, because it's these social issues that are actually impacting their health far more than what you can do in that clinic visit or hospital visit. And if you don't acknowledge those things, then your satisfaction as a doctor is going to be significantly lower, because you don't have the tools. You've been trained with the wrong tools when you're trying to, quote, fix things in healthcare. So I think it's that general kind of idea. I don't know if you have anything else to add.
Thank you very much. Erin and I are thinking along the same lines about this next question being relevant to all three of our panelists, and that's, do you anticipate vaccine hesitation that's been present for other past diseases will be a major issue for COVID-19? And I can see a response coming from all three, and because we're almost out of time, I think this is going to have to be the last question and the last opportunity for each of our panelists to say a word. So do you anticipate vaccine hesitation will be a major issue for COVID-19? Can we start with Chip Schooley?
It already is beginning to, it's already clear that it is a major issue. The proportion of the public who said they would be first in line to get a vaccine has plummeted since the spring, and a lot of this has been due to the politicization of the whole process. What the public wants to see in drugs and vaccines is that they have been rigorously evaluated and felt to be safe and effective by independent parties. And when they become tools of a political process, faith in the vaccines and in the drugs is eroded, and people will stand back. So I think it already is a problem and will be a problem if a vaccine is ultimately approved by the FDA.
Thanks,
Chip. I would agree. But even in a non-politicized situation such as flu in previous years, the CDC, despite huge efforts, has never really been able to get flu vaccination programs, anywhere near 100% for a variety of reasons. I don't believe this is. Non-public information, but the CDC does look at the number of lives saved if everybody were to be vaccinated just for flu, and we're just talking about flu deaths. We think we would save somewhere around 100,000 lives a year, because the lives aren't just impacted by flu, but by complications of flu.
Okay, thank you very much, Tim. And Jenny and Mia, any final comments on the situation regarding vaccine hesitation in Navajo Nation?
Yeah, I echo what Dr. Schooley and Dr. Stenzel have said. They're definitely, many of our patients have said, oh, I'll get the flu shot, but you're not giving me that other shot. Are you referring to the non-existent COVID shot? So, and I think one interesting thing that has come up very recently is because we were hit very early on, there has been a lot of interest in doing studies here as well and in recruiting Native patients. And I think we are constantly, struggling with exactly how to do that in the most ethical way possible. It's so important to include Native patients in studies like this, but understanding the historical trauma, and that many of the federal government and science, where many Native patients have felt targeted and have felt like guinea pigs, it's really hard to recruit people to a study with some of the historical context and trauma in the past. So it's been really interesting to just hear these conversations happening across our hospital system, across from our patients and across Navajo Nation. I don't know if there is clearly a right or wrong answer to how it should be incorporated into Navajo Nation, both the testing and the ultimate rollout.
Yeah, and I wonder if it's simply the request of kind of the Navajo area and the Navajo Nation for patients to enroll in these trials. And I wonder how there's hesitation around that. I wonder if that hadn't been encouraged or kind of pushed, if once vaccine is available later on and approved, if that will actually impact uptake later on because of this kind of uncertainty now of being tested on, and whether people will feel like they're still being potentially tested on with fully fledged approved vaccine later.
Or if that would make them more comfortable
more
adopting it.
comfortable, right.
It's really hard to predict.
If it shows that it's very, so this has been an active conversation here because there is one vaccine trial happening in Navajo Nation.
Yeah. Well, we have more questions than we have time, and I'm sure that we could go on for quite a while talking about these absolutely critical questions of life or death in the current situation. I want to heartily thank all of our panelists for this splendid session, which I believe is one of our best quarterly conversations we've ever had. With that, I'd like to turn it over for a final wrap up back to Rolla.
Thank you, Dr. Shortash, for acting as our MC this afternoon. We wanted to give one more thank you to all the speakers and all of our tabling orgs that have participated today, and our co-sponsors and the global health student leaders and advising staff that made this event possible. As a reminder, the extra credit form is posted in the Zoom chat. And thank you so much for attending. Have a wonderful rest of the afternoon. For those of you interested in attending our MA info session, please stay on this link as we will be getting that presentation very soon. So thank you so much, everyone.
Thank you very much.
Thanks, everybody.
Bye. Thank you. Yeah.
Yeah. Oh.